maybe a little healthy snack and ready for more. Just looking to see, I can see people coming back online. That's great. And we've started the recording again. Fantastic. Okay, we are ready to carry on. So we are at item number 6 on our agenda. And this is a great, I'm not going to steal Tim's thunder, but really, really happy to see this coming forward. It is a fantastic report. I always think that this point in the year when we get the annual report from public health is a great opportunity for us to reflect and look forward. And I'm delighted to see the report that we have in front of us today. But I won't go on anymore because this is Tim's paper. So Tim, I will hand over to you and you can take us through the report. Thank you.
Thank you very much, Chair. I'm delighted to be able to present the report today. The report has quite a few outings. It's going out to the IJB at Argyll and Bute tomorrow, and then we'll have loads of about half a dozen different outings at councils and committees over the next couple of months. But this is its first appearance in public, its debut. The report is, the covering paper is set out within the board papers, and also the presentation that I'm about to show is also within the board papers. The report itself is essentially an electronic document. The link is in the agenda, and that's how a great deal of the great majority of people will find it. We are able to produce it in different formats, both to increase accessibility and people who would prefer to have a written copy. We only produced a couple of written copies last year for a couple of elected members of one of the councils. But if people are looking for different ways to access it, we're more than happy to do that. And that's particularly important because, as you'll have seen, the theme for the report this year is health inequalities. I was toying with a fancier title. I tried a fancier title last year, but I gave up and thought, well, it's about health inequalities, so let's call it health inequalities. So without more ado, I shall share my screen. So hopefully people are able to see that. I shall just move on to the first slide. Health inequalities, I think, is something which is absolutely core and at the heart of the NHS. Many people will say, oh, we really thank the NHS for the treatment that we received and had a fantastic time from the NHS. And clearly that's true, and that's what the health service delivers, but so do pretty well all health services throughout the world. And the health professionals who work in those services, by and large, give a really good service, and people are grateful for them. Even in parts of the world where there are considerable inequalities, when people receive the healthcare, they're grateful for that, and the healthcare is often of a very good quality. To use a modern phrase, the unique selling point, as it were, of the NHS is health inequalities. It is that the NHS is available to everybody. Everybody gets that service, and everybody gets that service free at the point of need. And that was the way that the founders of the NHS set it up to be. We've had challenges over the years in order to do that, and of course many people know, and has been highlighted, some of the origins of the NHS are in Highland and with the Highland Health Service, and the way that that was able to provide services to everybody with in even the most rural areas, and even to the people who were poorest. So we've got that background to work with from the past, and that background to focus for the future, crucial to the work of NHS Highland. Fiona's already mentioned the population and public health impact and importance for services, and the focus on prevention, and many of those were picked up in the First Minister's recent speech. So health inequalities, picking up on prevention report 2 years ago, health inequalities are really vital for how we work to improve people's health, to help people to live a longer and happier life wherever they are, whoever they are, and whatever their circumstances across Highland. We see that in populations, but we also see that in individuals, with individual people who have difficulty accessing services and who have particular poor health because of their circumstances. And it's something that we need to have as the basis for strategies in the future and as the basis for how we work in the board. There are an awful lot of reasons for health inequality, for difference in health. Some of them relate to circumstances of individuals or communities. Particularly, we focus on income, but there are other origins and reasons for inequality. Some of them are around protected characteristics, and they're often related to not just the origin, but also to access to care. And there's a famous phrase which is quoted in the report around called the inverse care law from Julian Tudor Hart, who worked in the Swansea Valleys. I'll just read it out. The availability of good medical care tends to vary inversely with the need for it in the population served. There's a lot more to health inequalities than that, but I think that there is something that we all need to take really great cognizance of, and that's how people are accessing services, and above all, what's fair. Is it fair for people in different areas, in different circumstances, whether geographically, monetarily, or their particular individual characteristics, to have a difference in their health? I'll run through a few issues just quickly with the remaining few slides on different parts of the report. The great majority deals with different aspects of health inequalities. I can't cover absolutely everything because it's a vast area, and there are thousands of pages of research written on inequalities. So it's only scratching the surface and wanting to prompt action. But the report does cover some other areas and not just inequalities. And I think this is one of the more interesting ones. There's a chapter on general diseases within Highland. The report looks forward in terms of what we need to do, but it also looks back as a report on the health of people within Highland and Argyll and Bute over 2024. And this is one aspect of that, one of the collection of charts and graphs and information pointing to the great large volume of information that we've got elsewhere, but around different facets of health within our community. So I won't go through this one in detail. People can have a look at it at their leisure. The one thing I would say though is I do wonder how the burden of disease in the population relates to the time that we spend looking at those and the resources that we put into dealing with them. So for some of them, it's fairly straightforward. At the bottom is ischemic heart disease. So heart disease caused by reductions to blood flow is a really big problem, causes heart attacks and angina. Other things may be more of a surprise. There's self-harm and interpersonal violence, which is a major cause of premature death, and we are concerned about suicide particularly, but maybe that's something we need to give more thought to. There are mental health issues, Alzheimer's disease and dementia particularly prominently, but also depression. But what about headache disorders? How much time do we give thinking about that? So this is more just a put up for us to think about and to prompt perhaps some further discussion in the future for how we look at planning what services we do in general. Moving on to the particular focus on inequalities. As you'd expect, there are a wide range of charts within the report on inequalities. I think this is one of the most important ones, and shows life expectancy. Not an ideal statistic, but one I think that most people can relate to, and it shows, well, several very interesting things. One, of course, is the long-standing difference in life expectancy between men and women, which I'll leave that just as an issue hanging, but it's often not talked about, so I think it's just worth mentioning. And not suggesting that that either we can or we should make any particular changes on that, but it's um, worth a note. But more to the point is deprivation, so that we can see, as everybody knows, people who are rich live longer than people who are poor. But when we particularly look at men, the stark feature is the rising gap. So from the start of the century, the gap was um, so it's about 6 or 7 years probably, and it's risen now to around 10 years, and life expectancy for men has by and large continued to increase slowly, for rich men, but for men in poorer areas, it's remained largely flat. So we do need to think about what can we do to change that? What are the actions that we need to take within the communities and within our services to be aware of what is happening, and to look to tackle that. There are a whole range of things that we can look at and can study, of course, always in the background to action rather than just grandstanding. We look at national and international comparisons, and particularly when it comes to issues like drug-related deaths and inequalities there are really important. And often we look at how inequality works by comparing one group with another, particularly by wealth, by level of material deprivation. I'm not sure why we generally talk about deprivation rather than talk about affluence, but perhaps we ought to talk about both of those. Of course, for the areas where we live and work, there are other population group comparisons that are particularly important around access, around living in more rural and isolated areas. We can also look at comparison by risk factor, probably linked with things like geography and wealth. And these are different things that are looked at within the report. So alcohol is something that has a chapter to itself. We can look at outcomes for given conditions. We've got a chapter, for example, on cancers, just as an example of what we can do. I've talked about ease of access to treatment and inverse care law, and I think that's something that would benefit from an awful lot more thought around how easy it is and how fair it is around people accessing treatment, whether it's whether people are from particular communities where access is difficult, even if geographical access is quite close, or if people are in areas where geographical access to services is an awful lot harder because of distance and transport. And we need to think about what is fair in those circumstances, what can be provided, and how we work with communities, and how we consider the different inequalities and look at, as part of our future strategic approach, how we can work to reduce those and to increase overall health. I've just put this in. It's not in the report. I've just put something which some people may find amusing, but I think health inequalities in some way it is a slightly odd topic, because people talk about somebody suffering from health inequality. Well, they don't. No individual ever suffered from health inequality. No individual ever went to their doctor or their nurse saying, I've got a bad case of health inequality. People have poor health. And solving that is about improving their circumstances, including improving the underlying determinants of health, and also improving their access to services and the services that people receive. So in some ways, I put a rather facetious answer to the question that actually, from an epidemiological point of view, if you've got a bad case of health inequality, all you need to do is to move through a rich area, and your epidemiological life expectancy will automatically increase, but simply because you've moved, even though it'll make no difference to you. So I think why I put this up is just to, in a sense, a bit of a reality check, to think that to remind me and us all that we are thinking about the health of individuals. While we look at stuff at the population level, it all comes down to the individuals and how we can help them, maybe through population interventions. But we need to work in ways that are meaningful and impactful on individuals' health. Moving back to the more epidemiological picture, I think what we can see here is some good news and some not so good news. I don't want. I've done annual reports now. It's a very long time. Goes back to my first report was a public health report for the year 2002, which is a bit of a salutary. Salutary listen to me about how long things keep going on. And we have seen a lot of improvement. When I first did reports, I tended to be more about doom and gloom and talking about death rates. But I have, you may not believe this, I have become a bit more positive over the years. And I think it's important to point out some of the good news. So if you look on the right-hand side of this chart, we've got declines in women smoking at booking. We've got massive declines in smoking in general. We've got declining early deaths from cancer, and both of these are not only declining, but the gap between rich and poor is also declining. So I think it demonstrates that there is good news, and things both in absolute terms and in relative terms can get better. Not quite so good on the left-hand part of this slide. I mean, in some ways, coronary heart disease deaths, and they're going down, that's really good. But we are seeing an increase in inequalities. We still see high levels of smoking in some of our communities, poorer levels of access to primary care medication, secondary care treatment, and both the First Minister and the Chief Medical Officer have been particularly concerned about prevention of coronary heart disease, and I think it's important when we look at that to be aware of the inequalities. And again, a very high national priority is the drug-related deaths, and here we've got drug-related hospital admissions. See a little tiny bit of an improvement in the the most deprived areas over the last few years, but still there is not a good trend and a really big difference in inequalities. There are some inequalities which are very long-standing, and if not hidden, are perhaps not really talked about very much. And one of the chapters goes through some of these, talks about some protected characteristics and ethnic minority differences and things. But there are other ones that differences associated with people with particular conditions. And one of the most stark is learning disability. And here is one example of that. Life expectancy would be similar, but the percentage of people in good or very good health, comparing people with a diagnosed learning disability with the rest of the population, and the difference is huge. So really, I've put this up, and it's in the report to point out this as a stark example, but it's one of many examples where we need to think beyond wealth, think beyond geography, to include those, to think beyond protected characteristics, but also to remember the other aspects of looking at overall health, access to health, healthy lives, and people with a whole range of different conditions. So I set out lots of recommendations. I've also within the report got a section which is a bit bigger than last year's and a little bit more information around progress on recommendations from last year. I would want to emphasise when it comes to the recommendations that this it is a report. It's badged NHS Highland. It is a report which is coming here first. It is owned by NHS Highland, but it is an independent public health report, and the recommendations are not just for NHS Highland, and they're certainly not just for public health. Although public health within public health, we want to play our part in responding to the recommendations, but they are recommendations for a wide range of organisations, and above all, recommendations for how we all, in partnership, approach our planning and our strategy for the future to improve the health and well-being of people in Highland and Argyll and Bute. And probably the top recommendation is one I mentioned early on in the sort of introduction. It's simply about taking health inequalities seriously. So that brings the presentation to the end, and I will stop sharing and invite any comments or questions.
Don't know if you can hear me. My mic's stuck. You can. Okay, great. It was telling me that I was still muted. Thank you, Tim. Really, really loved this report. And like you said, people can click on the link to see the full report. I don't print many things off because I'm trying not to save paper, but this is one of the things that I am printing off and keeping in my folder because I thought this was just a fantastic report, really interesting. I've got a couple of questions, but I'll let colleagues come in first, and then I'll maybe ask my questions afterwards. So I've got Muriel first, please.
Thank you, Tim, for the report. I'm just wondering how we can fit this in with the new district partner planning strategies that are going ahead, and obviously our community partner planning. How do we fit in public health awareness for all members of the public? Because I think prevention and information are key if we are going to take strides forward. And I'm even thinking of public health awareness about things like frailty and loneliness and eating. It covers a whole raft of measures, and taking our young people with us, because I think that's key in our rural communities across the board of NHS Highland.
Shall I deal with the questions one by one, Chair? Is that just yes, Muriel, thank you very much. I think that's really, I suppose, a fundamental question around how we deal with any public health issue. We need to work with the various community partners we've got, and it's probably above all by recognising public health as everybody's business. Local government certainly recognises that, and a lot of the duties around public health are still with local government. And I think that there is, and always have been with local government, and I think that there are opportunities to do a whole range of different work with our districts and our community partners at a district level. But I think we have so many different partners, whether in GPs and other independent contractors, with the third sector, and just a whole load of community groups. But I think that the key is around mobilising those groups and those people to work with those of us in public health who can provide the information and provide the background, and we can do that at a community level, at a district level, at a partnership level, and then look at what evidence there is. But the delivery of activity needs to be the responsibility of the whole range of different groups, and we can't do public health to people. It's something that we need. We provide the background, we provide the evidence, we provide the support, and then the best sort of public health is done by the communities recognizing that and engaging with them and then working together. So that's quite a generic answer, but I think as we look at getting the prevention and the inequalities message in, and it's for communities to think. I think that the overall word health inequalities doesn't mean a real. I mean, perhaps if I thought of another title, it would have been something like fairness. So it's how can we make the individual communities, individual groups of people see how they can have, how fairness can come into their health and well-being.
Thanks, Tim. Before I bring others in, I wonder if I can just make an observation as to how this links with, bizarrely, the conversation we were having on finance, and to pick up Fiona's point about, the longer term, the bigger picture. I think that's part of it. And I think in some ways we can look at a report like this and be focused on how much of it is out with our control, but actually we have quite a lot of agency sitting around this virtual table here today. There's a huge amount of stuff that we can do as an organisation, and obviously that's picking up the point that Fiona made under the finance item. But I suppose I look at people sitting around this table and the other hats that they wear and other tables they sit around, and the communities that we live and work in, and how we can take it forward. And certainly I've been thinking about this in the community planning space, but of course Muriel within the council as well. So I think there's quite a lot we can do, and it's just sort of distilling that down. And obviously we've got Tim's really helpful recommendations, but I think that would be a key area of discussion and focus for us in the year to come. It is looking at where we do have agency and levers that we can pull to support this agenda.
Just pick up two things on that, Sarah. I think that I think sometimes health inequalities can feel a bit daunting, but I think we also need to recognise that there is something that all of us can do, and whatever our role is, in order to help to tackle inequalities. And two particular examples I've got. One is from my past, even before I came into public health, is actually, if I'm proud of anything I've ever done, it was around the approach I had to one particular patient when in the short time that I was a junior doctor, who'd been ignored by everybody else because he was an alcoholic and kept coming in and just lived on the streets. But I was able to find out something and make a diagnosis that actually made a difference to him. Now, other people do that all the time. There's nothing special particularly about my doing that, but I think that stuck with me as something that people can do. More recently, and more related to Highland, is a consultant from Raigmore who came to me, who said that he'd examined all the patients who came in to his clinics and looked at where they were from. And surprise, found that they were from the more deprived areas, and was wanting to look at what he could do and what those around him could do to help with other activities in those particular areas. So I think there are things, and that clearly extends way beyond to out to the different agencies, as you were saying, Sarah.
Yeah, no, that's good. Thank you, Tim. Okay, sorry, I've got some others waiting to come in patiently. I've got Steve next, please.
Thanks, Sarah. Thanks, Tim. And I like Sarah, really enjoyed the report. Just one observation, one question from me. So, just reflecting on Muriel's point about community planning board, and you mentioned the word looking for good mobilisers. I think that the Active Highland Strategy Group is one good mobiliser in terms of a potential systems-based approach to try to get people more active more often, which clearly has a clear population health benefit. And Tim, the thing I really like the way that you started the report with progress and recommendations from last year's reports, and that's where my question comes from. We talk quite a lot about social prescribing in the board. And I guess what I haven't seen, I'm not sure where to find how we evaluate the impact that social prescribing has. And I was looking with interest on community link officers, for example. I know that we've got quite a few right across the Highlands, and I found actually found a video, which was really good. That a couple of community link officers were talking about what they do, how they engage, and the impact that they make. But I'm not quite sure how we evaluate that. So if there is an outcomes framework, if we've got something, I'd be really interested if that could come back to the board at some point. Thank you.
Yes, I mean, I think there are. I'm tempted to say how we evaluate other things as well. I think we need to make sure that all we do gets that evaluation. There are metrics that are available, and we can certainly bring that back to the board and bring that to you, Steve, as well, around the community link working program. There are specific aspects where there's been where it's looked at, for example, the community link working as part of the Cairngorms Lottery project. We've also specifically got some evaluation work that was commissioned from UHI to look at community link working within a more remote and rural context, because that work hasn't been done. So there's a lot that can come back. Sometimes evaluating some of the public health interventions needs to be done in perhaps a more rounded way, and it's the outcomes can be a little longer, but we've got some good information, some good outcomes that we can certainly bring, and I can look into how that can be formatted for everybody.
Okay, lovely, thank you. And I've got Jerry next, please.
Thank you, Sarah. I suspect Tim has already picked up most of, if not all, of what I wanted to say, Sarah, and I've probably got a series of incoherent thoughts in my head rather than a. I think as always, I look forward every year to Tim's DPH report, because I think that they're always fascinating. But I think for me, what this one especially does, and it goes back to was it last year, Tim, where it was the social determinants of health as well. We went into that. I think these two reports together really, for me, articulate the challenge to the board. And I think for me, our challenge is really still much the same. Is how do we utilise these tools? And if I say it in our decision-making frameworks, so how do we actually begin to use an awful phrase, walk the walk rather than just talk the talk, and actually say, yes, well, we're actually going to utilise these key principles which Tim is setting out, whether it be in our resource allocation, whether it be in our service design. So if you take the vaccination, which we've just had approval for from Scottish Government to move that forward, how are we actually going to take some of these key delivery principles and actually say, yeah, we're going to do it this way, and actually, heaven forbid, it might actually cost us a little bit more money, but actually this is actually how we're going to allocate our resources into this, because we're getting the biggest impact on health inequalities, we're getting the biggest impact on health gains, because I think we've got to start looking at that, how that burden of disease is coming through to us, and not actually looking at necessarily the short term. So I suppose my question is, how do we as a board then actually begin to build that decision-making framework where we can actually see these principles getting used? And then that takes us into Steve's point, down the line, how do we begin to evaluate the outcome of these impacts? Appreciating that it could be 5, 10, 15 years away, because what really struck me when I was looking at one of Tim's graphs was that gap on life expectancy. For something to grow by, I think, 3 or 4 years in only 25 years is actually enormous statistically, for that life expectancy between the most and the least deprived to grow by that extent in such a small period of time. And I suspect it's going to continue to grow, because it's gone back to the financial crisis of 2007, 2008, and the whole austerity period which we've come through, the pandemic. I suspect there is still lots of issues in there which we're going to see coming through in the next 5, 6, 7, 8 years. Thank you, Sarah.
Sarah, if I come up with just two quick suggestions in response to Jerry, in terms of immediate actions. The first one is simply just being more aware. We've on things like the IPQR, and if we are actually conscious of what is there, there's been a bit of work on the IPQR, just as an example, around inequalities, and I think actually being conscious of that means that we won't ignore it. That's the first one. The secondly is where we need to improve services. We may well find that the improvements will particularly affect those in greatest need. So one example, I haven't got a slide of this, but if people want to have a look at it either now or afterwards, is page 43 of the report, where there are a couple of charts on vaccination, just bringing together a couple of things. And interesting that demonstrates that while we all know that we have had some decline in childhood vaccinations, which is a great concern, and there's a background to some of the improvements that we're looking to work on. That one of the charts showed that the decline is really disproportionately in the people from the more deprived areas. There's been little change in the rich areas, but it's in those poor areas. Now, I'm pleased to say that even in the poorer areas, that has turned round for the last quarter of information, getting back to that query about the difference in the 2 quarters from Argyll and Butte. It has turned around in Highland in the poorest areas in the last quarter, and I hope that will continue. But I think that's one example of where we see that people in rich areas can probably get by, make good use of the services, even if the service is not quite so good. But for the people who need that help, we really need to put that in. So when we are looking at service improvement, particularly for the services that need most improvement, I think we need to take a conscious effort. We're likely, by improving that service, to help the poorest, but I think we can also add to that by making a conscious improvement to target that in the areas of greatest need.
Thanks, Tim. And I'll come to Anne next, please, and then we'll wrap this one up.
Thanks, Sarah. So I think that Jerry's really brought the discussion nicely together in terms of how are we actually going to embed an approach to inequalities right throughout the organisation. And just to pick up on a few things that people have said, to go back to Muriel's point, which was absolutely on the button in terms of how our community planning and district planning structures can help us with this approach. It just struck me, do the terms of reference for our district planning groups include anything about population health or inequalities? They maybe do, but I think there's just one example of how perhaps we need to look at our governance structures and where these issues are addressed, where they're surfaced in the organisation, and whether that's the most effective structure for addressing this issue. I think data is the next one. Tim's examples are really interesting. So I think there's a challenge there for FPR and our strategy and transformation team, and how we can continue to develop the data that we have, not just at board level in the IPQR, but how we are able to make it easy for that kind of consultant who is interested in these issues in relation to their own service, how all of our staff can see how inequalities issues are surfacing themselves in terms of the services that they're delivering. And in terms of resource allocation, for example, a question that was in my mind, I'm not necessarily expecting an answer today, take our GP and enhanced services contracts. Now, I know that allocation of resources in a rural and remote context is a tricky issue for addressing deprivation, but how do we skew the allocation of resources to GP activity in relation to deprivation was another thought that popped into my head. But overall, Sarah, I think what I would like to propose something to the board today, and that's that we not merely note Tim's report, that we actually accept his recommendations and ask Fiona and our exec colleagues to consider what would be the most appropriate way to bring forward a 6-monthly and 12-monthly report on how we've responded to those recommendations and how we're going to take forward some of the ideas that have come up today in the discussion. Thanks.
Thanks, Anne. I really welcome that recommendation, that idea that you've just put forward. I don't know, Fiona, well, Tim or Fiona, did you want to come in on that? Because obviously we'll need to take that and think about how we do that. Fiona?
Well, I'm going to work on the basis that Tim will think that's an excellent idea, but he can let me know if he doesn't, because I'm sure he wouldn't have come forward with these recommendations unless he thought they were very excellent. As I was saying earlier, I think we've got to start to mainstream and take very seriously the type of approaches and areas that Tim's highlighted in his report and the recommendations. I was very thoughtful as Tim was talking there about areas that we maybe don't look at as frequently as we should. And to me, that is a nod that our governance needs a bit of a thought. If we're not looking at the data around the impact of a learning disability on somebody's life chances and outcomes, then we're not doing right by our population, or not sufficiently regularly doing right to check in with our direction and our strategy. So, I mean, and I think that's a really good suggestion. Obviously, it's not for me to decide, it's for the board to decide, but I would endorse that suggestion that you've made, to give ourselves that challenge and accountability about moving in this direction and embracing it right across the organisation. So I'd certainly be comfortable with your proposal, and to go away and think about how we then best offer assurance of that activity.
Yeah, and I can see lots of nods. So I think Anne's proposal is absolutely the right thing to do. So we were originally being asked to note and discuss, but if we can reflect in the minute that we've note discussed, and in fact we want to accept the recommendations in Tim's report and find an appropriate governance route to review progress at 6 and 12 months. And we are being offered substantial assurance with regards to that report. Members happy with that? Yeah, great. Lovely. Thank you, Anne. And thank you, Tim. Fantastic report, as I said, really, really happy. And I urge everybody to read it and share it and promote it and talk about it in all your different forums. Okay. This segues beautifully into item number 7, which is our health and wellbeing strategy. And I'd like to invite Gareth to speak to this item, please.
Thanks, Chair. The final version of the workforce wellbeing strategy has come to the board today for final approval. It's been through an extensive process of development and consultation, as outlined in the paper, and sets out our direction of travel and the areas of focus for us as an organisation, focused on our people and making NHS Highland a great place to work. The key things from this is this is not a standing start. We already have a range of work underway and support for staff. It's about building on and enhancing what we do, and there will be more detail developed as we go forward with the specific action and the action plan that will underpin this, and that will get reported back through our staff governance processes. So it has been reviewed by Area Partnership Forum Staff Governance, and as I say, it's been a widespread consultation, and it's here for final approval today.
That's great. Thank you, Gareth. Okay, I'd like to open up for questions and comments, please, on our health and wellbeing strategy. I'll start. Well, first of all, I'd just like to say thank you for the paper, and actually the way it was written. I found as I was reading through it, questions that I was coming up with, the paper was then answering as I was reading through it. So you preempted a lot of the things that I wanted to ask. I suppose the first thing to do is just to really welcome the paper. I think it's it's something that I know has been on the horizon for a while. I'd like to commend the engagement and the work that's gone into it. I think it's really positive. And to build on that, I suppose I have a question about how we plan to continue that kind of level of engagement, because it'll be iterative. I feel like this is, a first swipe at it. It's a very good swipe. It's a first swipe, and I'm sure things will evolve as it kind of progresses. So I just want to understand how we are baking in that engagement to make sure that future iterations reflect the experience of our staff. And I suppose my second question was that really this is, the content of the plan has come from staff through that engagement. But I recognise that it still might be very challenging for them to actually deliver the actions, given the the capacity and things like that. So just wondered if you could say a little bit more about how we're going to be supporting staff throughout the organisation, managers, leaders, to actually deliver what's set out in the strategy and in the implementation plan. Thanks.
Yeah. Okay, so I think you're spot on in terms of the evolution and the evolutionary nature of this. I think the important aspect of this was to have something that I suppose articulated at an organizational level our strategy, which we didn't have as a key document to summarize what we were already doing. And I think that's an important observation in terms of a number of strands of work where we know there's a lot of things happening, but we don't always publicize them in a way that's concise. So that's one purpose of the strategy, if you like, to say, here's what we're doing, here's what we want to do. So again, with that being easily digestible, so it doesn't have too much, it's not too long, because people don't read really long strategies. Staff members don't. So in terms of baking in, the wellbeing group will continue. We've revised the membership of that now to reflect going into action, if you like. And I think what we'll need to do is look at, probably similar to a subsequent strategy that will come to the board in the next board meeting, equality, diversity and inclusion, is an ongoing engagement around evolving the strategy and the action plan. So that's how we'll do that. And I think we'll also look at how we use the approaches we have used this time round. For example, Engagement HQ, which is a new engagement platform we're using, along with going out through the existing engagement processes and groups we talked about earlier in the board meeting, to gather people's views. So I suppose it's providing assurance back to the board. We'll keep it on. There's a structure there that will help us do that, and we just need to keep doing that, and we need to iterate the plan as we go forwards. The second point, I think, is really at the level of the detail of the action plan. So one of the key things we'll be looking at, and we discussed actually yesterday in the People and Culture Portfolio Board, was a proposal around wellbeing champions as one of the first steps into resourcing this, because I think we've also just talked about it being everybody's business to some extent. So there's stuff we do, there's elements of this that we'll deliver as an organisation quite clearly within our remit. So the occupational health service and support for staff, those elements. Spiritual care is a service that we provide in terms of pastoral care for staff. But there is a strong element here about how collectively as a staff body we look out for each other and support each other. So that's probably the more, I suppose, challenging element of any aspect of the work we do as an organisation, is where there's an element of building that into our staff's way of working, and time out to do that. So wellbeing champions will be a test of change, if you like, in that context, and seeing where the proposal is to allow a certain amount of time out to be able to get some training on that, but to be a point of contact in the organisation at the shop floor, if you like, to be known as a champion, to be able to go, okay, they can promote well-being, they can really get this out to the shop floor and say, here's the things you can access. So it will be, as with all of these things, when we talk about it, the competing demands on people's time, it is going to be challenging. So that's one part of it. The other aspect of it is building into people's practice, particularly leaders and managers. So, practices, we know that the evidence shows that compassionate or caring leaders have in their teams better outcomes in terms of sickness absence rates. That's been proven by several different studies in that context. So that's a lot about people's everyday practice. Do they have a pause in the day? Do they to debrief? Do they create space for connection within the workspace between people? So that's about also people taking that responsibility on. So again, about training and access to that. And we've also noted as a board that is also challenging in terms of the number of initiatives, if you like, in terms of where we're trying to improve and increase people's understanding and knowledge and experience in that leadership and management space. And the number of courses we potentially get into saying all managers should do. So it relates back to what we talked about earlier, is how do we create time and space? Protected learning time is a discussion we've been having. We will be expected to look at as an organisation. Building that in capacity in the workforce planning is part of that. So a bit of a long-winded answer, but there's a number of facets to it. And it's really, I suppose, how we build the time and space into people's everyday working lives, whether that's a member of staff or a line manager, to be able to develop themselves into the kind of well-being practices.
No, that's really helpful. Thank you, Gareth. Okay, Muriel, I'll bring you in, please.
Gareth, thank you for that report, and it's great to see the evolution of it. One thing I'm interested in finding out, does this reflect the cultural diversity of some of the staff? It doesn't matter where people are based, but I think it's important that we capture that as well and include that in any board development going forward, or team development that you're doing going forward.
So I think you've highlighted a crossover with the Equality, Diversity and Inclusion strategy, which will be coming to the next board meeting. And one aspect of that is the overlap in terms of, it just comes off the top of my head, in terms of looking at training around what's referred to, whether you like the term, there's lots of different terms, but cultural humility, there's training around understanding cultural difference. So again, that plays into how teams interact and dynamics within teams. So if that's kind of angle you're coming from in terms of that overlap, that will be picked up within the diversity and inclusion strategy.
Okay, that's great. Thank you. And Steve, I'll bring you in, please.
Thanks, Sarah. Thanks, Gareth. I just wanted to say how much I like the strategy, Gareth. I know you've taken it to staff governance at least once, but the way that you've articulated the leadership side of things, I think is really good. And based on your empathetic leadership, based on values and culture, which I think is going to be super important. It is now, but as the organisation moves forward, I just think if we can continue to emphasise that, management is, we know it's all about stuff and numbers, and we've got some great managers in the organisation. But I think the people and turbulence side of things, making sure we invest in managers at all levels to make them great leaders, is super important. And I've had a look at the leadership programme. I think it's great. We just need to roll it out as fast as we can. Thank you.
I'll just come back on that briefly then. Technology challenges. So I couldn't agree more. And it's when sometimes the mind tends to boggle a little bit with this in terms of the interrelationships between different elements and trying to articulate that clearly. But you've done a really great job there, and I think the aspect for us we're looking at next is we are having a lot of uptake of the new modules that we've developed. There's still work underway in relation to further development of our range of offerings, if you like, as an organisation around training and development. The one thing we have talked about, but we haven't quite got there yet, is which is coming soon in the next couple of weeks in terms of proposal, is to look at a cohort-based approach to training. So it's a more of a proactive, ensuring we've got certain tranches of management being really focused on. So some of that's been dependent on a training needs analysis and understanding where the gaps are. But we just as a kind of slight sidebar, we did have conversation at the endowments committee around funding some work specifically focused on our senior charge nurse and charge nurse cohort within the organisation, and that's one aspect where we'll look at building in offerings from the leadership development side of things. So we know that's probably the nursing and midwifery is one of the biggest staff groups in the organisation. So focusing on that management group will be probably quite impactful, but it's always a little bit dangerous getting into one sort of staff group rather than another, as they're all important. So that's why I think understanding the need and where the gaps are, and then focusing as well as a broad brushstroke approach to make sure that everybody's got access to the same opportunities on a self-serve basis is important as well. So yeah, that's definitely going to be an important part of it going forward.
Thanks, Gareth. And yes, if anybody thought earlier on that I was frowning at Gareth, I wasn't. I was frowning at my very slow mic button that wouldn't undo itself. Thank you. That was really helpful. Oh, Jerry, I'll bring you in and then we'll wrap this one up. Come on, Jerry.
I'm always loath to to make this comment, and I'm going to preface my comment by saying I really like the document and the strategy and the way it's presented. I have to comment though, especially given our previous item, that the EQIA is not yet completed. I did pick that up in the cover paper, Gareth, and actually thank you for acknowledging it, which is actually which is a good place. I just wondered what the timeline was for actually finishing that off, Gareth.
I'll take an action to confirm that to the next board meeting. But yeah, that's
okay. Good, perfect. Right. Well, thank you very much for taking us through that, Gareth. I mean, some great discussion. It's clearly very welcomed. It's a great step in the right direction. So we really look forward to seeing that evolve and develop as things go forward. And of course, there'll be detailed scrutiny, I'm sure, through the staff governance committee, and we'll hear about that again in due course, and we can pick up that action as per Jerry's request. So just to confirm, we are being offered substantial assurance. And we are being asked to approve the final strategy as we have it in front of us. Is everybody happy with that? Great. Lovely. Right, don't go anywhere, Gareth, because you're up again next. So we have item number 8. This is our Health and Care Staffing Act 2019. It's our Q2 report. Over to you.
Thank you very much. So this is the second of our reports. It has been, you'll note that obviously we're past Q3, so this is a little bit out of kilter in terms of governance, and as we work into next year, we reviewed our cycle for next year, so we're going to look at that so it makes sense. I'll just pause on that point first so we cover that off. There has been discussions at a national level looking at the fact the annual report needs to be effectively published before the end of the financial year, so it goes to Scottish Government in line with the legislation before the end of the financial year. So what we've agreed is that, and we'll clarify through staff governance as well, is the Q3 report will be submitted in the next governance cycle along with our annual report, and then we'll do a Q4 update in the first part of next financial year. So it seems a bit out of kilter, but let's just to make the clarity around that. So what we will do is effectively do a comparison in our annual report between this time last year and now for the Q3, if you like. So Q3 to Q3, we'll give you that annual reporting. And then there'll also be a note of what's happened in the last quarter, if you like. So a little bit confusing, but I think we've finally nailed how we're going to do it. So that's just that aspect of it, and we'll get a bit smoother going through that next year. In terms of the report itself, it has changed slightly in terms of the format and the layout, but again has generally been welcomed through the groups that have reviewed this, including the Area Partnership Forum and Staff Governance. And the key points, there's a lot of information in the paper, so I won't dive into too much detail. There are key areas to focus on going forwards, particularly highlighted in relation to red, if you like, the red, amber, green status. So standard operating procedures for real-time staffing, assessments and risk escalation. That's about introducing a standardized approach across the organization. There's lots of local processes in place. It's just ensuring we have a consistent organizational level process, and we're working through that at the moment. Similarly, there's a requirement to demonstrate this time to lead. Both of these SOPs or standard operating procedures are based on work that's been done at a national level, so they'll be consistent with what other boards are doing as well. I say a lot of information in there. The assurance is moderate in relation to our ability to demonstrate compliance with the Act, and consistency of systems and processes. So the two are insulated, that as we start to have more consistent processes at an organisational level, it will become easier, if you like, to demonstrate compliance with the Act. But I suppose that you've mentioned the point earlier, it's not always that easy to land on a single version of assurance. And this is probably a prime example of that. The secondary part of that assurance is that we have a clear plan and programme plan that is setting out the areas we are addressing to strengthen our approach. So that includes the points I've just made. But a good example would be, we have a plan to roll out a module called Safe Care as part of rostering. Rostering is on a rollout basis as well. So once that is fully rolled out to the whole organisation, that effectively means you can gather information for every single part of the organisation for rostered teams around the real-time staffing requirement. So at the moment, in the absence of that, will be done locally through local processes. So at an organisational level, it's quite challenging to collect that and provide that evidence in that comprehensive way. So that hopefully gives you a bit of a sense of the kind of challenge around demonstrating compliance in such a large organisation, and all boards are grappling with that as well. So I'll stop there, because I say there's a lot of information in there. So just to note, the last point was, we have now obviously under the requirements of the Act, the medical director and nurse director need to approve the report as well, and that has been endorsed by both directors.
Okay, that's great. Thank you, Gareth. And actually, I'll just pick up on your point that you made towards the end there about boards kind of grappling with, how to do this, how to report on this. And I suppose as I was reading through the report, as well as the sort of the sheer scale of it, as you've just described, I was also mindful that this is still very much kind of bedding in. We're still figuring out how the rhythm of this works, and how that's going to flow for us. And I suppose just a couple of questions about looking to peers, and have we had, or will we have, the opportunity to do a bit of comparing and see how other boards both are getting on in terms of assurance against the bits of the Act that we need to be assured about, but also that kind of reporting and data gathering and how we do that well. So that's my question before I open up.
So, as you might expect, there's variation in how people are doing this reporting. I think my position is that I've taken with this is that the detailed template that will be submitted as part of the annual report will be public. So the level of information we're providing is quite substantial in relation to that, and we've done that intentionally from the start, so that there would be no surprises when you come to publish that more detailed template. Some other boards have presented a much more summarized and less detailed report on that on a quarterly basis. I think that's for us to determine what we think is working for us. So we will see in due course more clarity around how people are approaching that, and also get feedback. So again, it'll be interesting to see what we get back in terms of feedback in relation to the reports when they're submitted. I suppose the only other caveat I've got is that during the course of pre-implementation, there was a lot of evolution of the templates, and so again, that kind of stopped at the point when implementation started. But I would not preclude there being further changes when they get a large volume of information in, whether they then further change the template. So I've taken a position based on what I've just described in terms of the level of detail we've got to provide, so that the board's seen all that throughout the year and there's no surprises at the end.
Yeah, no, okay, that's helpful. Thank you, Gareth. Jerry, I'll bring you in, please.
Thank you, Sarah. Gareth, I think I picked up in the paper, if I'm correct, that the health and the Act itself perhaps didn't introduce any new requirements, maybe perhaps just codified them all in a single place, but clearly the reporting of those and demonstrating compliance, as you say, is brand new and is presenting a challenge across the piece. What I would be interested to know, and maybe this is better directed at Boyd and Louise, though, is whether we think we're seeing any positive benefits now of being codified in a simple place, and actually a clarification of responsibilities, and whether that is actually making any positive impact upon service delivery.
Yeah, happy to come back on that. I think the nuance of that is that the way that it's been couched pre-implementation and implementation is, this is nothing new in terms of the practices that should be in place, and in relation to, for example, real-time staffing, clinical advice, professional standards is one aspect of it, and workforce planning is another part of that. So I think that was the essence of it. I think it does codify it, as you'd say, which then places more of a requirement to be able to demonstrate that you have it in place. I think that was a way of articulating this is not yet another thing layered on top. However, the reporting requirement is an additional requirement, so you can't get away from that. However, the positives are, I would say, that through the programme boards and the engagement we've had from staff, it has been positively received. And whilst it's a bit of a burden in some respects, when you actually get to speaking to people, and there's various varying levels of what I call engagement, but not in a negative way. It's just everybody's aware of it and doing it. It's time to get to go engage with the programme. But when you do get engagement and speak to folk, it has been positively received. And in a way, that's part of how presenting it as being a useful thing, as opposed to a burden, is probably the key. So again, I think having more robust, consistent approaches to how we workforce plan it's all in our interest to have that, and it's about how you present it. I think is the most important thing. So I want to commend my colleagues for the support around that, because a lot of that's been led by professional leads with a particular passion for this, and that's what's made the difference, I think.
Thanks, Gareth. And I think, Louise, did you want to come in on that as well?
I did, yes. And first of all, to endorse everything Gareth said in relation to how it's been received. I think the next step, though, is how we use it and how people see it being used, because it could go one way or it could go the other. We've got to get that balance right, and that is very much where Gareth, myself, Boyd, and others have to be joined at the hip about how we do this the right way for the organisation, for the communities, etc. Which is tricky, because I think the importance for me is also looking at how we do service redesign and service planning alongside workforce. And it's not just we're looking at how many nurses we need, we're looking at how many doctors we need, etc., etc. It has to be that picture in the round. And that is difficult, else we'd have been doing it well for years. So I think we're in a good place, but the proof of the pudding is going to be over the next year or two.
Well, that's a helpful perspective. Thank you, Louise. I'm just conscious that I'm running a little bit behind time, so I will take Joanne, and then we will move on. Over to you, Joanne. Oh, you're having trouble with your mic. Okay. We can maybe pick it up offline, or you can send it to us and we can pick it up at another point. Okay. Right. So sorry, that just caught me on the hoof a little bit. So we are being asked to note the requirements as per the Act and take moderate assurance based on the information provided in the paper. Are we happy to do that? Yes. Okay, lovely. Thank you very much. Now, if you remember, we're swapping the agenda around a little bit. So poor Gareth is not getting a break yet. And we are he'll be very glad for lunch when it comes. So we're going to take item number 10 now. We're just rejigging a little bit. So this is our Highland Integrated Care Service. It's a paper on the model of delivery. So I'm going to hand over to Gareth again for this one, and then we'll take a break after that.
Thank you very much. I will just note that due to the nature of the subject and the kind of, I suppose, governance dance between the organisations, there's a sort of coordination, the choreography, can't even say the word, choreography to when things have gone where, but to provide assurance to the board that we've been represented at every single stage of those conversations and discussions. There is a lot of background to this in relation to the National Care Service, but there's also background in relation to discussions that have been, I suppose, ongoing probably for a number of years, but also more recently with Fiona taking up post and Derek taking up post in the council, and those relationships continuing to develop between, continue to develop based on some of the same players and some new players on the pitch in relation to both organisations. So I think there's an important dual path here that's been described to the board over the last 6 months. And one of those drivers was the National Care Service Bill, which we now know has been significantly altered in relation to the proposals as to how it's going to progress, particularly in relation to part 1. This isn't in the paper, I'm just providing this as additional context since the paper was written, in that part 1 will be removed, which is the part that includes the proposals around removing lead agency model. So although we started with an element of a driver around potentially removing the lead agency model, that has changed over the last wee while. However, in parallel, we've been having conversations around the model of integration and models of care between both organisations, and whether there's opportunities for us to review that and determine if it will enable us, what options are available to us in that context, and within those different options, how might they enable us to progress and build on what we have already as two organisations working together to improve outcomes for our communities and our people. That was just probably a bit of the background. We moved to a point where I think the critical point where there's agreement between the two organisations to review the model formally, and I think that's the key point of the paper. We're not preempting a decision that one model or another is better. There's more conversation. I think the key point is we've reached a critical decision point between both organisations to progress on that basis and establish a steering group. So that has gone to the council, and they've agreed that as a way forward. JMC has been involved in the process as well, and it's obviously we then progressed that through our own governance to bring to the board today to formalise the decision going forward from here. So I think there's opportunities. The commission work has already started, as agreed earlier last year, sort of mid to late last year, around starting to look at the evidence base around different integration models across Scotland, and what they may enable in terms of outcomes, what they may enable in terms of how people have worked together. There's also detail around what services have been included in the integration schemes. That varies across Scotland as well. So there's a number of moving parts in there in terms of the model of integration. It's not just about the corporate body, the body corporate, or the lead agency. It's also in relation to what has been included in the detail of the integration schemes. So that is, there's a lot to be done, and that's why I've commissioned the work to look at that and look at evidence base around what will help us going forwards in terms of enabling our transformation programme. But I'll finish on the point. I think that the positives are that we've reached a point where there's clear alignment on the potential, on the proposal to go forwards with formally reviewing the model of governance of integration, and the proposal to set up a steering group, and that's what's here for board discussion today. And obviously there will be a requirement to continue communication across multiple stakeholders. So this will be a complex piece of work as we take it forwards, but we've reached a key decision point for the board to approve.
Okay, now that's helpful. Thank you, Gareth. I wonder, before I open up for questions, I don't know, Fiona, did you want to add anything at this point, and then we can open up?
Thanks, Sarah. Yes, and thank you, Gareth, for opening that up and just taking people through. I suppose for me, maybe putting a more personal slant on it, that in the timeline that Gareth just outlined, where in June, when the amendments for the National Care Service were tabled and it was included in that lead agency would be removed, that triggered a conversation. But in essence, that's now become a local conversation rather than a national conversation, because that required us, as the only lead agency in Scotland, to challenge ourselves about whether we were optimally delivering integrated health and social care services. And I think particularly the very stringent focus on delayed discharges and the significantly disproportionate number that we have, particularly in our Highland area, indicates that we're not achieving outcomes in some key areas, such as delayed discharges, and we've touched on that in this meeting already, that we know that other parts of Scotland are able to achieve. So I think it's right and proper that we ask ourselves some quite searching questions about whether that's an operational issue, a tactical issue, or a strategic issue, or a combination of all of that. And that's what I think this steering group will need to be asking itself. Maybe the other element that I would just particularly reference is the work that we did in maintaining the capacity that we have in Moss Park. That piece of work through last autumn took very focused leadership from myself and from Derek Brown in the council and all of our teams. And I think that what we did was almost surprise ourselves by what we were able to achieve by working together in maybe a slightly different way than is laid out in the scheme of delegation and the lead agency model, where in those circumstances in the past we've probably worked more in isolation of each other than we did by absolutely working hand in glove last year. So that's not definitive, it's not a suggestion that there's something that's lacking, but I think it does prompt questions to be asked. And that's what we want the steering group to do, is to continue formally to ask ourselves those questions rather than just to speculate or to have those informal observations that I'm sharing with you today. But it certainly is enough for me to support the recommendations that are in this paper, that we're at a stage where, as two organisations, we want to take learning from the rest of Scotland. That's difficult to do when we're at cross purposes about our models, but we want to take our local learning and take some local agency of the decisions that lie ahead about what we think is right for the people of the Highlands. Thanks, Sarah.
Thanks, Fiona. Okay, I'm going to open up for questions, comments, any thoughts at all? I mean, clearly this is as a phrase used in another item, it is a bit of a journey, but this is quite a significant point in that journey for us. Anne, I'll bring you in, please.
Thanks, Sarah. So I support the recommendations, Fiona. However, I think any of us who are aware of the level of work and focus that the development of these models took originally are probably aware that this might take quite a lot of effort, especially if the decision is taken in the future to change the models. So I guess there's risk there as well as opportunity. So I wondered if you could just say a little bit about how you think we can ensure that taking this forward doesn't take resources and focus away from the extremely pressing problems that you've mentioned, such as delayed discharge. And should we be thinking about possibly placing a risk on our risk register around that particular conundrum? I don't know. But your thoughts on that would be appreciated. And I just wanted also to ask whether we know whether this is yet agreed with the council, whether the reporting mechanism for this work will be the GMC or whether it will be the council and the health board individually, but choreographed, as Gareth mentioned earlier. Thanks.
Thanks, Anne. So just to pick up your first question, I suppose what I've been particularly struck with, and I was reflecting hopefully in my earlier report, is how much activity that we're undertaking to try and maintain the status quo. So Catherine and her team have had to engage a really significant change in the way that they're doing the management of flow in the hospital. She talked about that in relation to a question earlier. And all of that is to try and keep the show on the road because of the way and the numbers that we have of delayed discharges in our hospital sites. So for me, the tension that there is about how we utilise our resource has to be balanced between what we think's going to do the right thing by people now and provide the best outcomes in the status quo, but also to commit ourselves to what do we need to change so that that context improves and changes over time. And I think where Derek and I have got to in our discussions is that we feel that without tackling this particular aspect, that we can't really get to the root causes of some of the issues of our status quo model. If I thought there was a way that we could definitively shift that without going down this road, that would seem optimal in terms of, as you say, the resource that it will take to shift. But I suppose I'm just not convinced that that's going to be possible. I think we've as an unintended consequence, baked in some of the causes of the problems that we now have, and nobody intended to do that. I think it was absolutely right and innovative at the time to try and take forward this way of operating. But I think what we've seen over the passage of time are those unintended consequences coming through. But I accept your point, Anne. It's an ambitious thing to do. It's a brave thing to do, and it does there provide risk as well as opportunity. So I think probably the question about how we record that and whether we record that in our risk register, in the shared risk register, these I think will be some of the early questions that we need to pick up within the steering group. I think the purpose of the steering group is to shape some of the detailed moves of the choreography. Don't want to overly push that metaphor, but I think the steering group need to establish its terms of operation and where it reports to, which I think also then picks up whether the reporting comes back to the board and council as two separate entities, or whether we want to channel all of the reporting through the JMC. I don't think that's a decision that I can take individually. It has to be a collective decision along with council colleagues. But so I think that the answer is that has to be agreed through the steering group as we get that group up and running. That would be my suggestion and recommendation. Thank you.
Thanks, Fiona. And I think Gareth wanted to come in as well.
I suppose when we talk about risk, we also then talk about mitigation. So I think one of the conversations is noted in the paper and discussions we've had to date is recognition that this will any change, that both looking at potential for change and also implementing any change will have a resource implication yet to be determined, if you like, until the full implementation. But I think there's recognition among a number of parties, including the Scottish Government, that we would potentially require resource to be able to enable this. So I think back to when integration was first being implemented, there was an element of additional resource allocation around shadow boards, etc. So that's probably just articulating that we've got to have that conversation in the steering group about what's this going to require, so it doesn't impact on day-to-day business, but we also then can proceed with our I suppose strategic intentions. And I suppose that applies to all of our work there, where we've got to keep the day-to-day business going, but also think about how do we transform the system at the same time. So I suppose it's a principle that applies to all of the work we're thinking in that transformation space. Not saying we are definitely go down that route, but we've got to allocate some resource to be able to shift us forward as an organisation. That's something we need to think about.
Thanks, Gareth. And I think that's really important from the other aspect as well, is that we could all look to this new potential on the horizon, but actually we can't take our foot off the gas within the current model at all, and that's going to be a balance that we have to strike. I suppose the other thing I just wanted to pick up on was in relation to the appendix. So it's good to see that there is a joint communication plan that has been added in there for us to see. And I think that's going to be of critical importance. I know that people within our communities, a question on their lips is, well, well, what difference does this make for me? How will the care I receive be any different just because you've changed some governance structures or whatever? And I think that's going to be something we have to think carefully about. And also, as kind of picked up in that comms strategy, our staff as well. Again, what difference does it make for me today? And I think that will be something that, again, the steering group can give some more consideration to, but it's going to be important that we have a really solid comms plan around that. But Fiona, I'll bring you in.
Thanks, Sarah. I mean, I think in terms of our communities and individuals, the implementation of the joint strategic plan is critical in terms of how we change services to better meet the needs of our population. So I think that what we need to do is ensure that as we're communicating about the change of model, that we really emphasise how that supports the delivery of the joint strategic plan, rather than anyone thinking that the governance in and of itself is going to affect the care that's delivered to an individual. The delivery of the plan and the activity and the care and our practice is where people should start to see a change in what they experience. And the model is there to support and assure that, not to do anything in and of itself. So I think that will be important, that we really ensure that we're communicating well, not just about this particular piece of work, but about the implementation of the joint strategic plan and the transformational plans that both ourselves and the council have, with an exciting vision of seeing things differently in the future, with care being delivered at or very close to people's homes.
Thanks, Fiona. Okay, I'm not seeing any other hands up, so I'm just, because this is there's quite a lot in the recommendation here, so I'm just going to read it out so everybody's clear. So we are being asked to note that preparatory work will be undertaken to identify the optimal future care delivery in Highland and to make recommendations on modifications to the care and governance model currently in place in Highland. We're being asked to agree to create a strategic steering group to oversee the required work, with representation from both the lead agencies, including councillor and officer representation from both the Highland Council and executive and non-executive directors from NHS Highland. And we're being asked to agree the approach to joint communications advice in the paper to ensure that all stakeholders are fully appraised of plans as they evolve and have the chance to shape them. Everybody happy with that? Great. Okay, thank you very much, everybody. Let's take a break now. We'll take 30 minutes and I will see you back then, where we will be taking item number 9. Thank you.